patient groups I would most consider for the new oral anticoagulants would be people who have been unable to take warfarin, maybe because of side effects such as hair loss or diarrhea, or that their INR could not be stabilised, so I'd be concerned about their risk of bleeding due to an erratic response to their therapy. After that group, I think we need to look at those who are at high risk of possibly intracranial bleed, where we know that these agents are much safer than warfarin, and I would like to try and see how I could find that cohort of patients and initiate them next.
What the current NICE guidance says is when you have patients who are on warfarin, you need to discuss, the clinician needs to discuss with the patients the benefits and the risks of switching from warfarin to dabigatran in light of their current INR control. Ad hoc analysis suggests that the benefits of dabigatran may be reduced for patients who already have good INR control. So there may need to be some discussion around staying on warfarin if that's going to give the greatest benefit in terms of stroke prevention. For patients who are struggling to maintain their INR in range, there would definitely be a case, a stronger case for discussing switching to dabigatran or rivaroxaban.
I think we need to identify patients who are currently taking warfarin where this may not necessarily be the best form of therapy. A simple test would be to look at the individual time in therapeutic range to see if they spend more of their time out of range and therefore unprotected from their warfarin therapy. Another assessment would be to see patients who over maybe a 6-month period have thrown off 2 or 3 high INR readings above 5 for no clear reason, because they are patients at risk of bleeding, although they are being protected by warfarin. A novel agent would be a way to protect them against their stroke as well as that bleeding risk. If somebody's just been diagnosed with atrial fibrillation, we know that that's a real opportunity to start an anticoagulant. So I'd be very keen to impress on the patient the need for therapy. The therapy that I would first advocate would be warfarin, because I know it to be effective and affordable and reduce their risk of stroke. However, in line with the NICE guidance, if the patient was to discuss their desire to go on to dabigatran or rivaroxaban, I would have to comply with the section 1.2 that says we've had a discussion and we have decided to use a new agent. When we're looking at patients with atrial fibrillation, not only do we have to consider their stroke risk, but we also have to consider their risks of therapy through bleeding. I feel these new agents give us an advantage in the fact that we know their general bleeding risk is lower. I think we should be cautious though, where we are concerned more about GI bleeding, that their risk is similar if not greater than warfarin, and their real advantage comes from the patients where we're concerned about intercerebral bleed, where they clearly are superior. As a general practitioner and one of the national clinical leads for atrial fibrillation, I have to say that one of the biggest problems we have is under anticoagulation of our high-risk AF population. I think we need to recognise that aspirin is an ineffectual agent, and we are now in a world not with one anticoagulant but many and more on the way, and we should anticoagulate atrial fibrillation.